Dear colleagues from all over the world, aesthetics in dentistry is more important than ever before. And of course, we want to learn from the best. And this is exactly what we will do now. So let's welcome Istvan Urban to our webinar today. This webinar is organized and hosted by Geistlich, and it is part of the Webinar World Tour. The title is The Reconstruction of the Peri and Inter-Implant Papilla. A few words about Dr. Urban. He teaches implant dentistry in the graduate program at Loma Linda University. He is licensed in the state of California, USA, and has a private practice but also a training center in Budapest. He graduated as a dentist and as a medical doctor at the Semmelweis University, and he completed a full-time program in oral surgery. Since 2012, he holds a PhD in periodontology. In case you have any questions about the webinar and its content, please type them in the dedicated area of that platform. So let's get started now. Dr. Urban, the stage is yours.
Hi, I'm Istvan Urban, and today I'd like to talk to you about the peri and the inter-implant papilla reconstruction, which is a very, very interesting topic. And I will utilize bone and soft tissue reconstructions together. And I will show you some of the long-term results we have and some of the new results we have, some of the really recent developments in this topic. I will the base of my presentation is going to be based on some of the scientific papers and case studies we published, and some of them are not published yet. So the problem is this. Okay, a patient's coming is a young patient who has this high smile line, and this patient is losing the central incisor, and this patient, at least the central incisor, maybe the lateral incisor, there's no papilla, there is no bone around the tooth, so what shall we do? And as you can see here, I'm probing, there's no interdental bone either, no buccal bone, no palatinal bone, so unfortunately, this tooth is probably gone. And the other tooth doesn't have any bone, and I want to reconstruct it. I want to have a papilla like this. So, I mean, that would be the idea, right? That's what we would dream of. So, basically, this is the topic of mine. Well, we have also multiple missing teeth on young patients. As you can see here, this poor patient at age 23 lost, 4 teeth, and now we have a vertical defect. And obviously, we want to have a good foundation of the bone, but this patient needs to smile. And so, how many teeth? How many implants? Is a bridge better than single implants? Now, obviously, that's what we think, but I will challenge that also. And one thing, like a little summary of the biology of the papilla. Here you can see a central incisor which is going to be extracted, but you can see here beautiful papilla, symmetrical, good central incisor papilla. Once you extract the tooth, you can have around like 1.5 millimeters of loss of the papilla. You will have, okay? Because the interdental tissue becomes like facial tissue. And, a lot of people don't think about it now, because then, I'm extracting the tooth, is safer, then I'm going to place an implant later. That's good. I'm going to do a bone graft, perfect. But what about the papilla? Is it going to come back? Or is that okay that it's asymmetrical, that, on one side shorter than the other? Or can I do something to bring it back? So, historically, the biggest advantage of immediate implant placement was that we were extracting a tooth and we were able to preserve the architecture of the soft tissue, at least interdental. Buccally, it was a bit more challenging. So here I'm just going to slide through preservation of the peri-implant papilla. And you can see here, that was the extraction. That was like an immediate tooth replacement, basically. You can see here the tissue that is really frozen now. And now we placed a permanent crown here. And that is restored, whatever, older design implant, because this is like a long time ago. Because I was lucky enough to be involved with immediate implant placements, the end of 90s at Loma Linda University with Dr. Joseph Kahn, who was one of our, professors. And so as you can see here, that's a couple of years later. I think that's about 6 years later. That's 12 years later. And you can still see, was easy. I mean, I just extracted a tooth. We did something like a customized healing abutment or an immediate provisional to preserve the soft tissues. And I also did something on the buccal to be able to preserve that. Now, the problem began when there was 2 teeth that you had to extract. And here you can see inflamed tissue. The bony peak is missing already because of the inflammation. And so here we placed 2 implants. And here we used 2 types of implants. One was a little bit like a tissue level type of design of implant. The other one was more like a bone level type of design of implant. It doesn't really matter, but we did it a long time ago. This is the 5-year follow-up on the case. And you can see the 2 implants. You can see a pretty much perfect inter-implant papilla. But again, that was a preservation. We did one by one. We waited a little bit longer in between. And this is 12 years later. So you can see here at 12 years, you can conclude that this was time tested. Now we had obviously teeth which have no buccal bone, no palatinal bone like this tooth. And then, everything was flapless. So yes, you can potentially do this flapless, but what if you make a flap? It's like, then you make 2 vertical incisions in the middle, which is like in the aesthetic zone, it's maybe not the best idea to do. However, maybe for papilla-wise, it should be pretty much not bad. As you can see here, we were able to reconstruct the buccal bone, the palatinal bone, place the implant, and used a tissue graft, also a soft tissue graft, and have, now we focus a little bit on the bone, the buccal bone, and the palatinal bone. That's good. This was like an average type of, aesthetic type of neat patient, but this one, this patient has a high smile line, and this patient is going to miss the central incisor, and there's a 12 millimeter pocket, there's a fracture, there's like a fistula, there's, like a chronic infection here. So when I extracted, there was a defect. And here, again, there's different ways to do this, okay? There's maybe a way that you can do this potentially flapless, but here's a flap. But that now we started to utilize a microsurgical flap. And here we did the following. We placed an implant, we did a bone graft inside the socket, outside of the socket. We did a micro type of suture fixation of a membrane like a sausage. We did a customized healing abutment because we didn't have enough, stability, we felt, to do a provisional. And then we did a microsurgical approach. Here, the same patient that I'm suturing with a 7 and an 8. And look at the 7-0 looks like a rope. Okay, the 7-0 is sometimes too big. So then we use 8-0s. And with Dr. Ken, we published a paper on this type of patients, predominantly, basically on his results. And we are also following up on this type of patients for the last 15 years. As you can see here, here just places, this case is again like a preservation of the papilla. Now I did 2 vertical incisions. I did a microsuture, and as you can see here, is a high smile line patient. Maybe the shade of the crown is good, maybe the shape is not perfect, but look at the vertical incisions. Do you think it's disturbing? Well, I don't really see them so disturbing because they were really nicely sutured and adapted. Good. When a patient is coming to you that there is no more tooth, there is nothing to discuss because the papilla is gone, at least 1.5 millimeters. So we have done a classification. For single teeth, when we extracted a tooth, like at least 6 months ago, it's not like 2 months ago when you still have some walls of bone, but 6 months ago, then there is class 1 is a horizontal defect, but we started to look at the bony peaks, which are supporting the kind of, reduced papillary height, but there's good bone support underneath. So class 1 is a patient who has a horizontal defect and has intact bony peaks. And for these patients, here you can see a moderate horizontal bone resorption. We placed an implant and simultaneous GBR, and then a soft tissue graft on the fascia, but at the same time, we were pushing in like an ovate pontic provisional to provide, to start to form, later on the tissue. And then provisional here, as you can see here, then we form the tissue. And so here, you can see that we were able to, with the intact bony peak, bring back the papilla. Well, let's restore this. So here's a restoration, symmetrical distal papilla, a nice mesial papilla. And here it is at 15 years. And you can see here, there's not much of an asymmetry. There's no asymmetry. The papilla is pretty much to perfection, but this was an easy case. Except that this patient already had a chronic defect and extraction was done, so some of the reduction of the papilla had to be dealt with. A class 2 patient is the same thing, intact bony peak, but now there's a vertical defect. Usually, we're not placing an implant and simultaneously a bone graft. In this type of patients, we're going to do a bone graft 2-stage. So we do a bone graft first, and you can see the perfect bony peaks here. And you can see here the mesial papilla is kind of like blunt. So even though, what do we learn here? Even though the bony peak is intact, it doesn't necessarily mean that you have a papilla. So now we have pretty much perfect bone for this patient. We place the implant, but now we started to reconstruct the papilla. And the first way of reconstruction was that we did a big, thick sashimi type of connective tissue graft from the anterior, usually the anterior maxilla or way in the posterior. And you can see here. And then we sometimes everted it and closed it. Now, when I look at this closure, I would criticize myself in several ways. The connective tissue, same thing, but let's see what happened. So then we started to develop an uncovery with a provisional, the first an uncovery, which we called the push-up papilla uncovery, when we push the tissue on the buccal and interproximal. And you can see here, we started to gain back some papilla. It's not the original perfect papilla, but it's a positive, good architecture at 1 year. And this is at 8 years. Papilla is obviously better at 8 years, to 10 years. And then at 15 years of follow-up. So here's like an original, kind of like traditional way, which we're much better than this today, but it still worked pretty well. The class 3 patient is the one which is very interesting. The class 3 patient is a patient who has a combination defect, a ridge defect and a periodontal loss of the bony peak at least some point. And you can see here a high smile line patient who has, there was an implant here, a bone graft here, and you can see here the lateral incisor is still a piece of bone coming out. Okay, so you need to obviously clean that out first, and then you go back and you can see here a combined defect. So there's a vertical, horizontal defect, plus the bony peak is a little bit higher up. So what we did in this type of patients, we started to do, again, it's a historical case. We started to do a ridge augmentation and put some autogenous bone directly on the roots. We didn't have any, I would say didn't have any finances maybe of the patient to, even put a growth factor on the root. And obviously it would be better with a growth factor. But then we took again an anterior maxillary sashimi type of connective tissue graft in one piece, as big as it gets. And that's a lot of things. Now you do a non-resolvable membrane, a resolvable membrane, a bone graft on the root, plus a big sashimi type of connective tissue graft is not easy to close. So anyway, we were managing the closure. And as you can see here, there's a lot of tissue gain. So here is the tissue height. You can see the vertical, you can see the horizontal height, and you can see here a little bony peak on the root of the lateral incisor. So yeah, this is not a very highly scalloped patient. So that's kind of like a lock. But if you look at the papilla that's completely missing, and now it's pretty much symmetrical to the other side, you say that, yeah, this is success, and here it is at 7 years later. You see the little bony peak graft that I did. And it's not perfectly sufficient, but it's still there after 7 years. Good. Other solutions. So here's another one when I had to remove an implant. So the patient was referred to me that the implant had to be removed, and you can see here that on that lateral incisor, which had some root resorption because of orthodontics, and you see here there's some graft material that's moving around that root. So the root is almost completely exposed. So I removed the implant, but I didn't remove the tooth because the tooth was not that mobile. And, we have a rule. If it's a single tooth and there is some bone loss on the neighboring teeth, we try to do as good as it gets to try to pretty much stabilize the situation and maybe even grow some bone and soft tissue on the neighboring teeth. So here's what we did. Did a bone graft and then added some, again, bone, but now on some growth factor, which was amelogenin, on the root surface. As you can see on the left video, now I put some autogenous chips on the root surface. The bone graft was a mixture of inorganic bovine bone mineral and autogenous bone, a non-resorbable bone membrane in combination with a microsutured resorbable bone membrane and the connective tissue graft on the top. Why connective tissue? Because these palatinal connective tissues were not that strong for the papilla, so we may need another one at the time of implant placement. And of course, I'm gonna show you a much better way to do this. But anyway, let's look what happened. Here it is, the implant, and you can see some bone on the root. So please look at that. And you can see on the X-ray, now we root planed almost to the apex, and we have I would say, if I measure this, it's close to 2 millimeters of newly formed bone on the root. And then it's a long abutment, which on a not a tissue level, but a little bit of a machine color implant, which is a little bit sticking out of the bone. And this is a follow-up on this case. This is at 7 years. We could have a longer apical margin of this crown, but that's another, aspect of discussion. No probing, okay? So we were able to save the tooth in the neighboring, and we have a very nice level of papilla here that we were able to reconstruct with this. Good. Here's another tooth which was upon extraction. We extracted the tooth because there was a fracture, a trauma, and because of the trauma, because of the fracture, it was there for maybe two weeks. That tooth should have been extracted, and now the infection went to the neighboring tooth, and now the lateral incisor is missing some of the root exposed with some of the bone from the root. So, but it's a 3-wall defect, so we didn't extract the lateral incisor. We just cleaned the lateral incisor, then we grafted it, and at the end, we placed an implant into that grafted bone, and we added a papillary bone graft. Okay, well, a C-shaped bone graft, which is quite of an adventure because we did that, over a decade ago. And again, in the roots, on the root surfaces, we used just autogenous chips. Then we used a collagen membrane and a connective tissue graft. And here is the papilla we were able to reconstruct. So this is the same way of doing it. And as you can see here, the central incisor, distal papilla was completely lacking. There was no bone, up to the 2/3 of the lateral incisor. And now it looks acceptable. And as you can see here, this is the red one is the bony peak graft. The blue one is the interdental bone graft that I did. Good. Now, this patient is a high smile line, complete asymmetry, lost papilla, and an implant is coming out because of, disease of the implant. After that implant had to be removed, you can see here complete loss almost the papilla of the distal side of the central incisor. And now it's a combination defect, a vertical defect, and some bone is missing on the root. And there's the bony peak. You can see here that it's reduced. So what we did in these cases, we have done a bone graft again. And once we did the bone graft, we tried to do some chips on the root, and you can see maybe a little bit of a bony peak is still not intact. And that's pure autogenous bone, and pure autogenous bone is going to remodel, so I should have done maybe a mini sausage on the top. Then a big sashimi type of connective tissue graft. You can see here the fat, the glands. But you know what? The good quality connective tissue graft, which was everted, okay? Now, please, I want to stop here a little bit. I'm going to show you something better that we do today, okay? But I just want to show you that if you would use a palatinal graft, and if you get really lucky, what would happen? Okay, so here's some amelogenin, again, some emdogain on the root, an everted connective tissue graft. And you can see here the growth of this papilla around the provisional. And you can see here that we use the new abutment, which has a little bit of a concavity. We call this abutment the push-up papilla abutment. As you can see here, it has a concavity on the fascia, convexity interproximal. If there is enough space, we push it in, and all of a sudden, the papilla is going to come down. So as you see here, the distal part of the central incisor, the papilla was all the way up, and now with bone grafting with a traditional connective tissue grafting from the palate, and with the push-up papilla abutment, we were able to reconstruct this papilla. Let's see what was the fate of this. That was the reconstruction. This is at 10 years. This is at 14 years. And you can see here this at 15 years. And you see I did a gray dot where the papilla should have been and where the papilla was and where it is after 15 years of loading. You can also see here there's a little recession everywhere except the implant after 15 years. So where do we recommend the pupa? Recommend the pupa if there is a loss of neighboring bony peak, but you need space. Or sometimes you have increased space. When you have increased space, even with bony peaks, you may try to use the pupa. And then also you can do a unilateral loss of bony peak. If there's unilateral loss of bony peak, then you can do a unilateral pupa. Like this patient had a unilateral pupa. You can see here there was an implant there. We had to remove, reconstructed the bone, the soft tissue, and the papilla with a pupa also. Okay, so good. So let's go back to this patient that I showed you very at the beginning. Okay, so the central incisor, if you probe, there is no buccal bone, no palatinal bone, and interdental bone is really, up to the apex. So we decided to extract the central incisor. Lateral incisor was absolutely intact except the interproximal bone, which was, going up to the 2/3 of this root. And you can see here another picture of the palatinal probing. Good. So all we did was a growth factor that we really cleaned the root, obviously. So very good root planing is very important. We use the Sabo mini curettes to clean that. And then we applied here another growth factor called the PDGF. If you don't have the PDGF, you can do, amelogenin or, there's another one, RegenFast, or just, nothing. Probably you're better off with the growth factor. Okay, so then some autogenous chips were applied directly on the root, and in the middle, the socket graft was, like a 50-50. And you can see here, I'm grafting without any buccal bone, and there's no membranes here. It's a socket graft, really densely packed, and then there is a collagen, a matrix, a mucograft seal, just to seal the defect here. The socket. Okay, in 6 months we went back, and you can see here the socket graft was like pretty much perfect. There's the buccal bone, there's the lingual bone, and the interproximal bone on the root, except the bony peak. Now we placed an implant, and you can see here the surgical guide, and we recognize that we're missing a little bit of the bony peak, yes, but maybe we can do that with a different type of connective tissue graft now. And this connective tissue graft is going to have two types of genetics. A little bit like a base connective tissue graft from the palate, which can be a deepitalized connective tissue graft or a subepithelial connective tissue graft as your preference. And the most important of all, a micro tuberosity graft where the papilla is, for both of the papilla. This is the interproximal iceberg. So I'm placing two mini papillas on the base connective tissue graft. And you can suture it here. You can suture it to the other side. Here you can apply again some of the growth factors here with the amelogenin on the root. But it's very important how you're going to close this. And here again, the important part is that we have a little bit of a tuberosity, not too much, because too much tuberosity will grow all over the place. But putting one connective tissue to the other one from the palate is not as powerful. Putting like these everted connective tissues, the big sashimi types that we did before, is very difficult. It's not as predictable for the papilla as this. And I always said that, some of the cases that I showed you that it was very difficult, and it was like, maybe I will never achieve that. But I was wrong, because once we started to recognize that we could do this, and then we had, the way of closure was also very, very, very important. This is like a vertical closure, papillary closure here with some different types of mattress sutures, such as horizontal and vertical matrices. And here maybe the flap could be a bit larger, but I think we're still able to manage. Now, as you can see here, vertical incision in the aesthetic zone. I showed you before, we use these micro loop sutures, 7 O's, 8 zeros, 6 O is a rope, so we're not really using that. And then it should heal much better. Then we can form the tissue with the provisional. As you can see here, the implant is placed according to the guide. You see it all like the soccer graft of the century here without the membrane. And here you see the three pieces of connective tissue grafts sutured together. Now it's placed where the papilla is with different types of sutures here. And then after the formation of the papilla. And you see here the finer crowns, the finer crown that is mimicking the color of the neighboring teeth. And here with a probe, and here is the X-ray. And here's the smile of the patient. As you see here, the high smile line. Patient has now a pretty much perfect papilla. And this is the original smile. Good. So now the next patient, is missing a lot of bone on the neighboring tooth and a lot of bone of the missing tooth. So, but when we opened it up and we did the extended safety flap for a potential papilla reconstruction or interproximal bone reconstruction here. Can I reconstruct this bone? It's like that would be, almost impossible to perfectly reconstruct. But I may be able to save this tooth and build this back with bone and soft tissue grafting to an acceptable level, which would be better than if I extract and then a big bone graft and then 2 implants or maybe 1 implant and a pontic. So here we use 2 different membranes. And what we did here is that we, again, exposed the area with the extended safety flap. And you can read that also in one of our articles, about the extended safety flap. And you can see here the sabo, mini curette to curette and clean the root. And then we have used here the PDGF growth factor, and we put some autogenous bone in there, and then the PDGF applied to the really clean root so that the PDGF gets into the tubules. Then the bone graft goes on the root. Then the remainder of the bone graft, so autogenous on the root, and the mixture of autogenous and anorganic bovine bone mineral on the defect, a perforated PTFE membrane, which cannot be too close to the neighboring tooth, so I'm going to need another membrane. And that other membrane is going to be a collagen membrane that's going to be pinned, fixated, but also microsutured around the lateral incisor. So here I am, I'm placing here a collagen membrane, pinning, and then microsuturing, and then closing the flap. And then you see here the bone formation, and there is clearly bone on the root. Now, we can place an implant. Obviously, there's still a lot of bone missing on this root. We can place now an implant and add some more chips on the root to make it a little bit more horizontal, not perfect, but the rest can be with a soft tissue graft. And now, again, it's going to be an interproximal iceberg, which is now sutured the base connective tissue and a baby tuberosity on the top. The baby tuberosity can be switched to the paramolar, which is very close to the tuberosity. That's already getting dense enough and maybe growing enough in patients who have almost like a tuberosity type of tissue around the second molars. But again, as normal, we would use a little tip of the tuberosity. And here I'm suturing the two, the papilla together, the 2 connective tissue together. I'm using a 7-0 resorbable monofilament suture, and I'm placing 3 mattress sutures to suture them together. And then the base connective tissue will receive like a little loop suture, goes around the one tooth, then goes around the other tooth. Okay, now we're going to suture this to the root. To the root, you can place, again, some type of growth factor like amelogenin to have a better connective tissue connection to the root. And you look at the bone. The bone is now, again, it was improved at the time of implant placement. So here's it's a series of steps, and this is what we call the safe track, the way I'm doing this. So now this suture, and then we will close. Okay, suture, close. And here's the schematic drawing, a base connective tissue graft with the baby papilla tuberosity on the top. And then we have used the buccal strip. And I'm going to go back to here, because I talked about this, we described this, we published this. They can take a strip from the bottom, below the teeth here, and then we do the strip in combination with the mucograft, which is an essential treatment for reconstructing the vestibule. And you can see here now we reconstructed the vestibule, and I did a nice reconstruction around this lateral incisor. And here you can see the radiographs, and there is a mini abutment on top of this implant, and there is no probing in here. And here's the final. So patient is pretty happy with this. Again, I said an acceptable level. It's not going to be a perfect papilla on the other side, but yes, it is an acceptable level. Good. So patients with big defects, they will need big bone grafts, obviously. And we published a paper on how to do that. And now the advantage is that you can also change the face of these type of patients. And but there's a lot of soft tissue defect for these type of patients, as you see here, because there's only one flap. You know, we're not even talking about the bone graft, but talking about the closure. There's only the buccal flap, and no matter where you make the incision, you make it more buccal, you still have to do sometimes the suborbicularis preparation when you lose the entire vestibule. And that is not so easy to reconstruct. Even you have perfect bone, not so easy to reconstruct all these soft tissues around these teeth and potentially even build the papilla. Okay, so here's a case before and after of this type of treatment, and an acceptable result, yes, with a perfect symmetrical smile for the patient. So again, the reconstruction of the vestibule, which is not on my topic today, but we're going to combine this with a papillary graft, because I want to introduce not only the iceberg, but the garage connective tissue graft. Okay, so as you see here, there's problems here, you know, in terms of, complete loss of the papilla. So just to review, what you're going to do is an apically positioned flap. Potentially there was already a connective tissue graft to make the tissue thicker, and then there will be the baby kind of like anaconda strip graft, a mini free gingival graft for source of cells, and the collagen matrix, which is the mucograft here. And you see here, patient is leaving like that, patient is coming back like that, and we have a picture of a 10-year follow-up on this strip gingival graft in combination with the collagen matrix, which is great. And you can see here, you know, this is a disaster case with 2 implants, papilla is lost, you can see the head of the implant, there is no vestibule, and with all these little things, you can bring these implants and revitalize these 2 implants, and this is how they're going to look. Okay, historical attempts, okay, historical attempts, and unfortunately, this is not historical in every, you know, there's still, you know, ongoing, which is like too many types of soft tissue grafts, okay, historical attempts. Here I did a bone graft, and I did a connective tissue graft number 1 during the bone graft. Then I placed, here's the connective tissue, number 1, good. Then I did, place the implants, I did another connective tissue graft. Then I did an open healing connective tissue graft for the vestibule. This was before the mucograft. And all of a sudden, yes, we did have kind of like a papilla. Good. You can see the strip, 1 year, 10 years, no change in the bone, 15 years, no change in the bone, 15 years, yes, there is a change in the papilla. It's a little bit of a reduction. Why? Because it's all palatinal and it's too many connective tissue grafts. It's, as you can see, it's not that beautiful. It's not flat, but we can do a much better job. We had to develop something better than this. And here's another one, which is nice and stable. Again, historical, 1 and 13 years later. Okay, so then we start to have these patients with this type of defects. And here we just published a paper on how to do all these steps with implant therapy in the compendium. And you can see here, the bone regeneration, I talked about it already. Okay, here's the bone. Then once we got the bone, we place the implants. We have here 2 types of surgical guides. We place the implant. Here is an iceberg. Now is a double iceberg. So a basal connective tissue graft, and it's 3 implants. And this iceberg in between the implants. And here you can see here, then we have done the the strip graft type of facial graft. Mini graft to reconstruct good color. Okay, when you take it from the facial, you get better color and an acceptable result with 3 implants. Good. So we got these patients who are coming into a clinic. Sometimes, this is 2 implants, and the implant is not that bad, but look at the papilla. I mean, obviously, the patient is not happy. Patient is like is a fake papilla. Is not even cleaning it. She's very, very unhappy. So we went back, and the bone was, the implants were not. I mean, the bone was, it was a graft, but it was not, the level we like. But we said, okay, we're gonna keep these implants. We just cleaned the area. Then we did, the implants are not even in the right place, as you can see here. And so I did an iceberg here. But after the iceberg, we got a good gain. We had to close the over the implants. So we used here electrolytes to really clean up the implants. But then we have no vestibule, and we don't really have perfectly the papilla. So now what we're going to do, we're going to combine the strip graft with a papillary connective tissue graft. We're going to create a garage in the previous connective tissue iceberg to improve further the papilla. And I think this is the best way that I've ever seen doing it. And so here I'm doing the apically positioned flap. So we have 2 zones. It's a modified apically positioned flap. The first zone is thick, then the apical zone is thin. Now we're going to suture this up, utilizing here a 6-0 resorbable suture. And then we're going to try to take the strip graft from the facial. We try to find some area where there's gingiva. Why? Because it will grow back, just it's going to be better color. So here we took it from the left side of the maxilla, and then we create kind of like the Chinese wall from keratinized tissue to keratinized tissue. We need only like a 2 millimeter strip. We have to consider the contraction and the shrinkage. So here it is, we're using the 7-0 monofilament sutures. Okay, so this is the micro-autogenous tissue graft. It's not that bad. Okay, now, why are we placing here an autogenous tissue graft in the previous autogenous tissue graft, which is now another little piece of tuberosity? Why? Because it can grow. I want the papilla to grow. So I will stick it in where the papilla is. I create a garage in the previous connective tissue graft, like storage room, like a fridge. And then I did do another little kind of like partial thickness flap, so I can just stretch it down and close the garage door. What is the advantage of this? Very good survival of this connective tissue graft because it's all embedded in vital tissue, and it is not going to make the color difficult. Then we take the mucograft. Mucograft is going to go in between the strip and here. What is the range? What is the role of the mucograft? It will allow the tissue cells from the strip to run through this mucograft, and then you will have nice looking keratinized tissue. Now we're going to have to expose these implants, the papilla push up, papillary uncovery, and then push in the papilla with the provisionals. And I'd like to really thank to the restorative colleagues here in our clinic, to Dr. Forster and Dr. Gross, to work on these cases so meticulously, because from this point it's still a lot of work. So you can see now that we just reconstructed it. And yes, you can see it's like there's still some tissue healing, but please take a look at that papilla in between the 2 implants. And that papilla coming from all back, and this is the smile of the patient. And here if I go back, yes, you can see here a little bit of that there was some plastic here, but this was like starting out as a disaster, and that is not really showing to the patient. The patient is seeing like nice color of gingiva and a nice type of papilla, and here before was all gone. Okay, so this was done with the iceberg and the garage connective tissue graft. Now, there's different ways to reconstruct the whole region, okay, for the anterior maxilla. The fast track, the safe track, and the technical track. The fast track is that we do a bone graft. Obviously, that implant was just unscrewed, do a bone graft. Then at the time of the implant placement, we do the bone graft, the implant, a kind of like a mini sausage, a mini bone graft, utilizing some anorganic bovine bone, a little bit of autogenous, and a collagen membrane. We do that to protect the bone all the time. And a papillary connective tissue graft. If the bony peak is intact, you don't need an iceberg. You can do a thick piece of subepithelial or deepithelialized connective tissue graft. Then, if we need a strip, because this patient had multiple surgeries, we take a strip from the buccal, and that's it. There's a 3rd surgery. And that the treatment time is 1 year, and you can get that crown back in 1 year. So it's not bad, okay? The safe track. The safe track has 4 stages, and that's for bigger cases. Stage 0 is the clean up the patient, stop smoking, and infection control. Okay, then you're gonna do a bone graft, and here you can see that I just did a sausage. Then I'm placing the implants. At the implant placement, I'm gonna do the mini sausage to protect. You can see here. Now I'll do the iceberg, okay? Base connective tissue, and I have 2 surgical guides, one papillary surgical guide to show where the papilla should be. So here I'm doing the base connective tissue, then I'm gonna take the baby iceberg and I'm gonna put it, inter-implant. This is the inter-implant iceberg, the one that I just showed you before. So I'm taking the mini tuberosity out, put it in the middle. Much better. Everything has a purpose. So the connective tissue graft is the purpose of thickness, and so we can have a nice sulcus around the implant. The mini tuberosity has the purpose to have a papilla in between the implants. And then, as you can see here, we need the strip, stage 4, the strip. Total treatment time is 15 months. 15 months, we have the uncovery, the provisional, and then the final. And you can see here the tip of the papilla between the 2 implants. That's actually 3 implants. In this case, this is a palatinal strip, so whiter color. And the mini sausage demonstrating stability, and this patient is many years in loading. Good. Okay, if the defect is not big, we don't need a strip graft. Okay, I want to explain that. For smaller cases, you don't need a strip graft. It's for larger defects or after multiple surgeries. This patient is young. Unfortunately, she lost her teeth, and due to an accident, the teeth are also basically lost. So here we're doing a socket graft using autogenous bone mix with anorganic bovine bone mineral, collagen matrix in there, and then patient is growing, a couple of years. When the patient comes back, the teeth are very long. Why? Because that is far away, higher up. The crest didn't grow down, and now you can see that we placed the implant, and it's just a couple of millimeters of vertical augmentation. And why not 2 implants? Because nobody wants 2 implants and a bridge. I mean, the bridge is not basically that the patient wants teeth. Okay, yes, the bridge, if you don't build the papilla back, is the best choice. But I think it has to be challenged. I think the bridge should be, historical in the future. It's a dead-end street. So here we're doing a bone graft. And after the bone graft, we're going to do a double iceberg now. But the patient is not going to have such a distortion because we're just gently moving the tissue. So there's not going to be need of a strip graft at the end. So here we just place the implant and then the bone graft simultaneously. So then 6 months you're ready basically. Then you do the connective tissue graft, and another 2-3 months. So basically 9 months you're ready with a case like this. And here's the base connective tissue, deepitalized, good quality connective tissue from the palate. Yeah, I completely agree with that the deepitalized connective tissue is very good quality, okay? But at the same time, anything, which is whiter is going to have a potential problem over time, which we didn't really see, before. Anyway, so I'm going to take the tuberosity, but I will never put the tuberosity that big here because then there would be also potential overgrowth. So, but I want to make sure that this connective tissue is completely stabilized. Okay, if any healing event problem occurs, this can survive by itself, even if it will be open. Then I'm going to take the tuberosity and do 2 connective tissues, one at one papilla, the other one at the other papilla. Okay, then I take the anatomical guide, and here I have the papilla future. And as you close it, you see a little bit of a distortion, which will bounce back. So you don't need to have any vestibular extension surgeries. Wanted to make it clear. Good. Then, so this is what we did. Okay, the partial thickness flap, the double connect. You need to leave a little bit more space because this papilla is still growing, but this patient now has 3 teeth. We also calculated growth, future growth in here. And yeah, she's happy with it. Good. In our dreams, we would like to make everything perfect, and here is a defect. Okay, I want to make clear that there's no way you can do just a soft tissue graft and implant placement, because then the implant would be way, way too palatinal. So you need a bone graft. You need the bone graft. You close the flap. You got the bone. Here's the bone. Place the implant, mini sausage, 2 implants and a bridge, perfect. Okay, we wanted to have 3 implants as the patient asked for us to do, have crowns. Now, when you have a big tuberosity, we call it an ice cube. In an ice cube, you can slice, you can do base connective tissue, and you can put the ice cubes or mini ice cubes or icebergs to where the papilla is. That's why you need like a papillary type of guide. And then you can do the strip gingival graft around, because that had to be, advance this flap really well. So here I'm doing the strip from the facial, from the mandible, and I can place it all over with the collagen matrix. Good. Then we provisionalize. Provisional, we go gradual, about 6 months. And if possible, we're going to use a zirconium provisional, because tissue just loves it. And then the first couple of millimeters, we don't want to modify. And then we just change the tissue scalloping here. And then we place the implants. I mean, the final crowns on the implants. And you can see here, those are 3 implants. And please watch the papilla between the lateral incisor, the central incisor. The papilla height is perfectly symmetrical to the central incisor implant and natural tooth. And so the color, because of the facial strip, is also not very, very nice. That's not a very nice picture, but it's a 7-year follow-up. Look at the papilla in between the lateral and the central incisor implant. So did I need a bridge here? I don't think I can get a bridge as good as this one. And you can see here on a CT scan how stable this bone is. And the bone is actually just perfectly supporting the lips. The patient can communicate, and the patient has like natural crowns. And you can see here another patient who has, the 2 teeth are missing, and it's completely flat. There's no papilla. Okay, and 1 implant is going in there with a resorbable, another one with a non-resorbable membrane. Okay, when we remove, and here's already a connective tissue a little bit on the facial and a collagen membrane. When we remove with a very small flap, we remove the non-resorbable membrane, you can evaluate the bone around the implant. Okay, then we have done the iceberg, and then a gradual uncovery of the implant. Well, here I made a mistake, and you can see here on the right side of the lateral incisor, the papilla there's no papilla. Okay, the closure was not the one that I explained to you. But in the middle, I think the job is done pretty well. Okay, so middle 2 implants, and pretty much the papilla is pretty much to perfection. So the peri-implant papilla reconstruction takes a lot of care, effort, using bone and soft tissue reconstructed procedures. The bottom line is you have to master the bone and the soft tissue, to get a papilla. And I hope you really enjoy this course or this lecture. And thank you very much for your attention. Goodbye.